All right, so again, hospitals are required to have a utilization review committee. They are required to review admissions, continued stay, and professional services in order to participate with Medicare. Patient status. This is kind of a busy slide. It has a lot to it. Patient status is something that people think is really, really easy, like your observation or your inpatient. And it's really, really not. It's really hard. And a lot of people in this room know that. It's hard to decide whether patients should be inpatient or observation. For our Medicare patients, if they're expected to need to stay in the hospital 1 midnight or less, they should be observation. For our other payers, it's usually 24 to 48 hours. I'm sorry for that typo there. It's largely contractual. How you're contracted with your payers will determine how you're going to be paid, whether it's observation or inpatient. Typically for OBS patients in the commercial world, there's no auth required for those admissions. However, the payers very often come back later and audit, and they will try to retract money later for patients that they think should have never been observation. OBS patients are typically patients who are coming in with symptoms. They have a headache, they have abdominal pain, chest pain, shortness of breath, less intense disease or illness, and less intense services for those patients. On the inpatient side, Medicare gave us the 2 midnight rule about 10 years ago. And basically what Medicare says is that for its patients, if a patient requires 2 midnights in the hospital for medically necessary services and care, they should be an inpatient. And 2 midnights start with the start of care. So if a patient is in your emergency room at 11:45 at night and their services start, that is the start of care. And as long as they cross that first midnight, right then, that's their first midnight. And you just need 1 more after that. It does not matter when the admission order goes in, it's when the care starts. Exceptions to the 2 midnight rule. If a patient dies, if they have an unplanned intubation, if they elect hospice, so a patient comes in really, really sick and they decide that they don't want to do continued care and they elect hospice, you can still leave that as an inpatient. Patients who leave AMA are also an exception. And then of course, the inpatient only list. If your patient has a surgery that has a CPT code on the inpatient only list, it must be inpatient or you're not going to get paid. For payers, it's often what the payer wants to pay, if they want it to be inpatient or not. But for most of us, we use evidence-based criteria to help us decide whether or not patients should be inpatient or not. Most everyone uses Interqual or Milliman. And then of course, it's very contractually based, whether how your hospital is contracted with your local insurance companies. For inpatients, these are patients who are going to be requiring more intense services, more severe illnesses. It's not symptoms, you have diagnoses. So it's not just abdominal pain, you really do have a bowel obstruction. It's not just a headache, they found a mass. There's a reason for the patient to be in the hospital, there's a diagnosis. Condition code 44. So when a Medicare patient is admitted to the hospital as an inpatient, and upon further review, it's determined that the patient should not have been inpatient, Medicare has us do a process called a condition code 44. This has only been around for about 20 years. Prior to that, if you found that your patient wasn't appropriate for inpatient, you just had to write the whole thing off. But about 20 years ago or so, they allowed hospitals to start doing condition code 44s. This process must be done in its entirety before the patient is discharged from your facility. So in order to change someone to observation, you need to change the order. You need to review it with a physician from your UR committee. And you have to go and talk to your patient in person and tell them that they are observation now. Is there something wrong? No, okay. Okay.
Yeah, somebody popped in because he made the elevator noise.
Oh, you don't see me anymore. It's Maureen. I can't see Hang on, maybe I can. Hang on. No, I can't. I don't want to. Okay. Well. Okay. So again, your patient must be notified in person. You need to go out and tell them it has to be done before they're discharged from your facility. And a very important thing to note with Medicare is that you can only bill observation time from the time the order goes in. You can't roll back to the beginning of that stay. So reimbursement for observation cases, it's typically an hourly rate and it's contractual. So sometimes you might be contracted for 24 hours, sometimes you might be contracted for 48, sometimes you might have more than that. But typically once the hours run out and whatever you're contracted with, you stop getting paid. So it's very important to make sure that you're managing your observation patients, reviewing them. We review them at least twice a day, if not more, to make sure that we are capturing upgrades when we can and facilitating discharges when we can. Sometimes you get case rates. So Medicare patients that have outpatient surgeries, we don't get paid observation time for those patients. We get paid like a case rate, almost like a DRG, where you get a lump sum of money for that stay and you don't get ops time. On the inpatient side, most often you have DRGs, so diagnostic related groups, where you get a lump sum of money from your insurance company or Medicare, and you have to treat that patient with whatever that lump sum is, whether they're in your hospital for 1 day or 2 or 3 or 4 or 5 or 500 sometimes, unfortunately. You do, once you do hit certain parameters of time, you do typically have outlier payments where you can get more money for those patients. But typically it's a DRG or a lump sum. And then you have per diem payers. We have a few here in Rhode Island that pay per diem typically. So you get a daily rate. You get a lump sum on day 1, a lump sum on day 2, and so on and so forth. The important thing to know there is that you usually get paid a lot more on day 1 than you do on the subsequent days. And your reimbursement goes down the longer the patient stay in your hospital. So keep that in mind. Even though you might be approved by your insurance company for that day, you might not be getting very much money to take care of that patient in your facility. So how do we know if we're doing a good job? There's a few different ways, mostly through auditing. I know personally, I review every write-off, every code 44, most of my denials that come in from payers. And sometimes you can glean some moments or areas for education of your staff based on how they're interpreting interqual or Milliman, if that's what you use, or the 2 midnight rule. If you have a patient that's being written off because they didn't cross 2 midnights, then you can go back to your staff and give them that feedback and education. And there's also something called PEPR that we can use, which I have a lot of stuff in my brain. I can never remember what PEPR stands for. I always have to refer back to it. It's the Program for Evaluating Payment Practice Report. So this is something that CMS gives hospitals quarterly, but it runs behind about 3 quarters. So it's old data, but it's good data for hospitals to use. Basically what it's telling you is how you compare to the hospitals in your state, in your region, and nationally for the number of discharges for a huge list of things that your hospital is discharging as an inpatient instead of outpatient. So this is just an example that I took from a CMS manual. The blue bar is the hospital that is supposed to be represented in this particular PEPR report. And all the red lines are the state, the jurisdiction, and national. So you can see that this hospital is discharging a lot less patients who have had a PCI as an inpatient than its other hospitals. So you can use this data to say, well, why aren't we discharging more patients? If all these other hospitals have 80% of their patients being discharged as an inpatient when they have a PCI, what are we doing different? Can we go and look and review? Are we upgrading patients when they're crossing a second midnight? If someone comes in with chest pain and they're ruling them out, and the next day, or they get admitted to observation, the next day they go for a cath, they need to stay another night for medically necessary treatment, they should be upgraded. Maybe you're not capturing all those upgrades. If this particular hospital's blue bar was way above all of those red lines, then that's something else you want to look at. You want to look and say, why are we discharging way more than all of our comparables? And sometimes there's reasons for that are really valid. So in the case of PCI, if you're working in a hospital that has a cath lab that does interventions, and you're surrounded by a lot of little hospitals that don't do it, then you should be an outlier probably. So it makes sense, but you should always audit. Use this information to audit yourself and to make sure that your hospital is doing it right, because you don't want to be non-compliant with Medicare. So these are some best practices that we've been doing at our facilities. About 10 years ago, not quite 10 years ago, we separated out from case management, and that's been great. We have nurses who are dedicated to when you do a combined role, it's hard to do both. It's really hard to do case management and discharge planning and pay attention and care about the the denials that are coming in. We do huddle calls with our case management partners daily. We need that. We need the information from the case managers because we can't do our job without them. We need their information that they've gained from interdisciplinary rounds, what they know about the patient. They're in the room talking to the patient. They can tell us what they look like, which can help us make our decisions better. And talk about barriers to discharge, our denied patients, all of our observation patients. It's very important. We're very lucky to have physician advisors available right to our nurses every day, doing our secondary reviews and peer-to-peers, which is wonderful. is embedded right in our medical record, which is great for ease of use, being able to see everything, no matter where you are or who you are, you're able to look at that. And one of the biggest things, honestly, that we've done is we've eliminated paper. So every fax that goes out, every fax that comes in is electronic. I can tell you, we used to have literally paper up to our hips of denial. Every denial letter is 10 pages long. And there's people in this room that can attest to this. We literally were like walking around stacks of paper that were up to our hips in our offices. So having that is wonderful, and it makes everything so much easier. You can very easily send something to the appeals team, to a doctor, to anyone, and they can just easily go into the record, look at it, pull up a denial letter, a denial log. You're not going back and searching through paper, diving in, trying to find something from 3 years ago on a piece of paper. Okay. So I was specifically asked to talk about PINs. We all know that the public health emergency is going away very soon. And with that, our Medicare fee-for-service SNF waivers are going with it. And we will no longer be able to discharge our patients to a SNF and have Medicare pay for it if they haven't had a 3-night stay in the hospital. It's been 3 years, been 3 really great years where we haven't had to worry about this, right? And we have a lot, at least we do, we have a lot of case managers that are new, that have only ever worked when the time of waiver has been in place. And you are nurses too, and physicians, providers aren't going to understand this, they don't know what this is. And patients are not going to understand this. They don't understand it to begin with. And you're going to have patients who are coming in who went to a SNF 6 months ago. or a year ago or 2 years ago from the ED, from being in observation, that's going to say, why are you telling me I have to pay $15,000 upfront to a SNF to go there? I didn't have to do this before. So it's going to be a trying time coming soon. So we're going to talk about HINs now. So social admissions. These are patients who are not safe for the community. They can't go home. They can't take care of themselves, but there's no medical necessity for them to actually be in the hospital. I always tell people we should try to discharge them custodially. Miracles do happen. I can tell you there was one time we had a patient who was from another part of the country and he was living with the family and demented, progressively getting worse. And their solution was to send him up here to live with another family member. So he moved in with the son and the daughter-in-law and the 2 kids and came Monday morning. The 2 adults go to work, the kids go to school, and dad gets picked up in the middle of the street by Providence police and it's delivered to Rhode Island Hospital. So clearly he was unable to discharge home. He only had Medicare Part A and B, no backups. But we knew based on his financial status, he was going to qualify. So I said, I remember it was Hope, one of our case managers. I said, can you please just try a SNF search and see what happens? And she very reluctantly did. And we got someone to take him Medicaid pending. And it was a miracle, but we did, and we discharged him. So you should always try, even if it's a 1% chance of getting it done, at least you've tried. And if they can't take a patient, then you've at least checked that off that you tried it. If you are unable to discharge them where they need to go, you have options of HINs or hospital issued notices of non-coverage, or ABNs potentially. With the other payers, the hospital is just denied and the case management staff and UM staff continue to work very hard to try to discharge the patients. So ABNs. An advanced beneficiary notice. This is for Medicare fee-for-service patients only. This is when you have a patient who's in your facility, who's observation, and you have a very safe and viable discharge for that patient in place. So, and they're just refusing that option. So this would be a patient who's admitted to observation overnight, the next afternoon is ready for discharge, but by the time all the discharge paperwork is done, they just don't want to go. And they're like, let me stay, I'm comfortable, I don't want to leave. This could be, as right now with our waivers in place, a patient who is in observation, has a bed at one particular SNF, doesn't want to go there, wants to go someplace else, down East Greenwich. We all know. And you can issue them an ABN and let them know that, okay, you can stay, but you're going to be charged an hourly rate for the rest of your time here. And the hourly rate is going to be particular to your own facility and how you would charge Medicare for that. So you can say, you can stay here, but it's going to cost you $200 an hour for the next, however, many hours you stay in the hospital. And very often when they hear that, they say, okay, I will call my daughter and go home. So HINs. HIN 1 and HIN 12 is really what we use. I put HIN 10 and HIN 11 on this screen just so people know that they exist, and for completeness, I have never issued one. I don't intend to ever do that. But just so you know that they exist, a HIN 10 is when the hospital thinks and UM thinks that a patient's ready for discharge, but the attending doesn't agree. You have the opportunity to send clinical information to your local QIO. Ours is KeyPro. Here in New England, for all of New England, it's KeyPro. You can send it to them and they will make an independent decision based on the facts of the chart. And like I said, we've never done it, but it's out there, it's available. HIN 11s are when there's a patient in the hospital who's Medicare fee for service and they're receiving some type of service that you don't think Medicare is going to pay for, and you want to be able to bill the patient. You issue them a HIN 11. I can't even imagine how this would happen, but it exists. So there's got to be something out there. So again, just so everyone knows that they exist. HIN 1 is what you're going to run into mostly delivering to patients in these social situations. We did one this weekend. The patient was admitted from their assisted living facility. They just couldn't take care of themselves anymore. They were failing, they couldn't walk to the dining room, and they couldn't get around enough that the assisted living could keep them there, because there's only so much assisted living can do. So they sent them to the ED and said she needs placement, right? So the patient was admitted for a placement. And I was on call this weekend, so I went in her chart and I looked to see if there was anything else going on with this patient, and there wasn't. So we issued an admission HIN to her. And we did end up placing her, I think, the next day. So she got out pretty quick. Pre-admission HINs, the liability of the HIN will be the day that you're issuing it. Admission HINs, the liability depends on when you are issuing the HIN to the patient, and when the admission order was written. So if a patient is admitted in the evening, and you come in to do your UR assignment the following morning, and you see this patient was just admitted for placement, there's nothing going on with them, they're not being treated in any way, and you recognize this patient needs an admission HIN. The admission order was yesterday. The liability is not going to be till tomorrow. So that protects the patient from being liable today, and gives you time to find placement for these patients. The point of HINs is not to make the patient liable for their stay. Truly, it's to make sure that your hospital is not billing Medicare for a patient who is not appropriate to be in your hospital, because you don't ever want to do that. And most of the time, what I tell especially my new staff that come in, if a patient can truly afford to pay for a SNF, when they get a HIN, they're gonna pay for their SNF most of the time. If they really can't afford it, they're either going to stay in the hospital while we maximize them and discharge them to the community, or eventually that patient is likely going to get Medicaid and won't get balance billed. You can't balance bill a Medicaid patient. So ultimately, very little liability, I think, ever actually gets to the patients. And it's really, truly just to make sure the hospitals are being compliant and not billing Medicare for these patients. So HIN 12s and discharge notices. So every inpatient Medicare patient, inpatients, are issued an important message from Medicare on admission, and then the follow-up is given within 2 days of discharge. If a patient does not want to discharge, they have the opportunity to appeal their discharge. They can call KEPRO, our local QIO, and ask them to appeal their discharge. They can say, I don't feel ready today. I don't want to go to this particular SNF. I want to wait. There's a bed someplace else tomorrow, and I want that one. I'm going to appeal my discharge. If a patient doesn't call within 4 hours, then we can issue them something called a HIN 12. Just gonna wait for the siren to go past. So patients have 4 hours from the time they receive the IM to call in their discharge appeal. If they don't, sorry. Okay, if they don't call in their appeal, the hospital can issue them something called a HIN 12. And what that does is it puts the liability for the stay on the patient, and it will always be the day after the HIN is issued. Most of the time, when you present a patient with a HIN 12 at that point, and you let them know you're going to be liable for your stay as of tomorrow, they say, I'm going to call KEPRO right now. And they do. All the time. I tell my staff, don't even get off the phone. Issue the detailed notice while you're there, while you're talking to them. Once they call KEPRO, we give them something called a detailed notice of discharge. And it's just a notice that lets them know why they're ready for discharge, or why we think they're ready for discharge, and why Medicare or their plan is not going to pay for them to stay in the hospital any longer. KEPRO will complete their review independently. I think they have 2 days to turn around their decision. And then if they agree with the hospital's discharge, the patient will always be liable at 12 noon the following day after they make their decision. It's always the case. Sometimes once that happens, we will follow up with another HIN-12 to the patient, because a lot of times KEPRO will tell them, you're going to be liable for your stay starting such and such a day at such and such time. And they're like, I don't care. I want to stay. I'm not leaving. I'm not taking that bed. I'm not going. So we will often come back with the HIN-12, because the HIN-12 has the dollar amount associated with the stay in the hospital. So it will tell them, you're going to be billed $3,000 a day if you decide to stay, or whatever your hospital is getting paid for by Medicare. And that sometimes, not always, will guide and gently guide that patient to accept the bed that's available that day, or go home with their family. So that's it. Any questions?